after inter only, then
ওরা
it can
ডাকতেছিলাম
add
তো
some
নে।
power.
হ্যাঁ
So
বল
the balance between the inflow and outflow should be accurate. And total height is also important thing because for every 6 inch total height, 11 millimeter of mercury pressure is increasing the intrapolar. So if the balance between the inflow and outflow is altered, then under pressure or over pressure can happen. If under pressure, then shallow and collapsed central chamber and the iris lens and posterior capsule can be collapsed centrally, and surge can be occur, posterior capsule can be tear up, and even during the surge, the endothelium can be decompensated. And if the overpressurized, the total height is more, in case there is a misdirection of the aqueous fluid and deepening of the anterior chamber, and the tip is not come close to the nucleus. The ultrasound is we know about the two mechanism, that is Jackhammer effect and cavitation effect, and it is shown that the cavitation effect produces near about 13,000 Fahrenheit and shock wave about 75 pound per inch. So 75% of the cavitation force and bubble, micro bubble, that is improved and produce this temperature. And this temperature is harmful for the animal. So for the guideline, it is given in the American Academy of Ophthalmology. For scalping, the linear control instead of fixed control. We know there is a power and all the things can be static. When we put it go to the desired level, then that is exerted. And linear, from the starting of the foot weight, it will be started. So linear is control is instead of fixed control in case of scalping, and pulse mode instead of continuous circle mode is preferable in case of scalping. And for chopping, they are saying pulse mode is better than the continuous. So in quadrant 1, the pulse cut is most effective method, and we know the pulse mode there is an on and off session. So reduce the power, excessive power, and reduce the endothelial. So I here show some picture of. I have no financial interest here. So some picture. These are the in different grade 1, 2, 3, 4 cataract. The same parameter, all the parameters are not the same. When the nucleus is hard, the parameter should be raised. I am showing this is a sampling one, and in case of power, you show that there is a linear, but the waveform is static in most of the cases. It is the important one. Same power is reduced. Now power is reduced and linear mode, and waveform and expression for it is in static position. So for the learner or beginner professor, then here is the in case of Ojit technique, there is torsional amplitude and photo power. We'll discuss later on about this. And epinucleus is similarly. So there are 3 to 4. One is continuous, one is pulse, one is burst, one is hyperpulse. So these are the Paco power that we can use. So in case of continuous, it can be fixed, it can be linear. So variable. In case of fixed, is so many disadvantages there. There is the nucleus is repulsion is occur, there is chattering occur, and there is heat production, unnecessary amount of necessary won't burn occur. Application scalping and quadrant occur. But in case of longitudinal continuous with variable power that is not fixed, the surgeon can titrate amount of power when he needed. But the disadvantages are the same. But in case of pulse mode, it can reduce the heat, it decreases the risk of home burn, and oftentimes allow aspiration to hold the nucleometer and can be hard to chop in the setting, and scalping chop secondary one we can use. In case of burst mode, it can reduce the heat to the needle and allow for the good function of the nucleus, that is holding, and for the surgeon to find sweet spot to stay in position 2 from the position 3. And
after 1 minute, you have 1 minute more.
I want to show one. Sorry. I want to show just one video. This is a black and red patient came to us for different consultation because our one eye has been done for consultation 14 years ago. Now she came, so we use the viscoelastic device, and we are putting. It should be a wave-like thing that put the endothelium and protect the endothelium. And in case of hard nuclear, we using we making a large stator in the center of the nucleus, and then we are going for this direct stop and stop. And at this stage, we are using the stop and stop is better than the continuous, the divide and conquer. And repeated viscoelastic substance can be added to reduce the endothelial softness. And if we think about the factoemulsification, so in factoemulsification is better than the iris plan or anterior chamber. It is better not to come into the anterior chamber. But in some cases, when there is no option, suppose people become small and there is a soft nucleus, and then lollipop technique is done. Here I am to show the in case of heart catheter, CD is only 30 to 1 and ultrasonic power time is 1.5. So there's a black catheter also can be done if you use the proper tool. So thank you.
Thank you, doctor. Now, for our last presentation, I'm inviting Dr. Rashid Alam to talk on advancement in the management of post-operative corneal edema. And at the same time, I'm requesting our respectable panelist, Professor Sarwar Alam, to take note on this topic.
Okay, sir. Thank you very much. Am I audible, sir?
Yes.
Thank you very much. So I'd like to give my gratitude to the scientific committee of the OSB for giving me the opportunity. So my topic is advancement in the management of post-operative corneal edema. So regarding this talk, I have no financial disclosure. So there are, after cataract surgery, if the patient having persistent corneal edema, it's very frustrating for the patient as well as the surgeon. And that's why I think in last 2 decades, there have been lots of procedure invented, like Descemet stripping, endothelial keratoplasty, automated Descemet stripping, endothelial keratoplasty, ultra-thin DSEK, DMEC, which was, I think, Dr. Price has invented this sophisticated surgery in 2008. And also DWAC, that is Descemet stripping without endothelial keratoplasty. Now the trial is going on for cultured corneal endothelial cell injection into the AC, and also a remarkable work by the Shigeru Kinoshita. Eye drop can also reduce the corneal edema. So a lot of things is going on, but I want to talk about the advancement in Bangladesh. So in the late 2019, we have started doing that is EK, DSEK and DMEC in Hispan Islamia. So for the DMEC is the that is you remove the disease endothelium and replace by the endothelial Descemet's complex without any stroma. That is the DMEC. And in case of DSEK, you remove the endothelium disease part and together with the Descemet's endothelium complex, and part of posterior stroma is also replaced. So this is I'm gonna share two of my cases. A 68 years old male came to our hospital with the edema, and he had done phaco in 8 years back, and after that he has developed that is dimness of vision and irritation and watering, and diagnosed a case of pseudophakic bullous keratopathy. And in mid 2019 he was done a DSEK by Vikash, and that was also failed. And after that, in December, I've done the DMEC in failed DSEK cases. So we got the tissue from Vision Share, excellent tissue, having 3,000 cell or more. So it was done in December 28th in Hispan Islamia. So this is the graft preparation. For the scoring, first I do a 9mm refining and doing the scoring, lifting, and that is stripping the Descemet membrane carefully. The Descemet after more than half part, we used to do a window for the F stump for the orientation, and final 8 mm disc graft is prepared, and it was stained and scored for insertion. This was the case I'm doing with the scale incision, 2.8 or 3.2 mm wide. So after that, decimeter axis, that is the diseased, that is failed endothelium is removed, and inferior PI is done to reduce the postoperative pupillary block glaucoma. Pupil is constricted, and then the Demel scroll is taken into the injector and introduced into the AC. Always keep in mind you have to put the stable that is the incision should be secure, and then flipping, and that is ripping of the scroll to unscrolling of the DM. Now the DM is almost unscrolled. You have to see the orientation. You have to find out the F mark. You can see the F mark over here. So when the F is visible, this is in the right orientation. Do the air bubbling, and after 2 hours, just this is the F mark. So fluid exchange is done for a little bit. So the first period the patient can see, you can see the F stump, and the enterocity shows excellent attachment of the DM, and the patient is having a good vision after 3 months, 618. This is my case too. This was a case of cerebrospinal bullous keratopathy. She has done the cataract surgery in our hospital in 2018 April. So it was done by the very senior surgeon, but still it can happen to anyone. So she was advised for DMEC in 24th October. So DMEC went well, but in the first period you can see the F mark. So the orientation is good. The ASOCT looked good. So I was happy. But after 7 days, I see this picture. She has developed the bullous keratopathy, and there is a detached DM and scrolling in the anterior chamber. And I was very worried. What can we do? So fortunately, we got the tissue that week, and we decided to do a dissect. So this is the tissue preparation of the manual dissect. So we do the incision of 400 microns. So the graft should be like 150 micron or so. So the dissect was we remove the epithelium and open up the wound, and you can see the folded, scrolled, detached DM is over here. So it was scrolled like anything, so you cannot do anything with that. So in this process, I saw something wrong in the 6 o'clock position. So it was the vitreous tag coming out from the inferior zonule. So I have done the meticulous AVT, and then inferior incision is done for the crocodile scissors, forceps, and the graft is taken in the Busin light, and it was introduced into the interchamber by the pull-through technique. So the graft is inside the AC. Now you wait for the centration, and after that, always secure the wound with the sutures, and air bubble is given. You can see the double edge of the graft. So now it's message time for the removing the interface fluid. So this, in the first POT, I have a suspicion that something wrong in that part. This part is all right, but here you can see some double that is slit. So I went for the OCT, and there was a interface fluid in the lower middle part. So I did the rebubbling. The next day, the cornea looks good. The ASOCT looks very nice. And after 7 days, the cornea is getting a bit clear, and I was happy. And the last month, the patient gets, she has an excellent vision of 6/9 with the, that is correction, and the patient was happy. So for DMEC selection, you have to understand the 10 no's. You don't have any synechia, no vitreous, no distorted pupil, no tubes, no iris defect, no high myopia or deep antechamber, no aphakia, no vitreous vitrectomized patient, no unstable IOL, and no hazy view. Other than this, you can do the DSEC very easily. So my gratitude to Vision Share for giving a tissue in this tight situation. My gratitude to Cornea Clinic also, and Vikash Mittal, my mentor. Thank you very much for the patient hearing, and I'd like to take some question. Thank you.
Thank you, Dr. Rashid, for your nice presentation and nice experience sharing. Now, I think our presentation part is over. So I'm requesting our panelists to give their valuable opinion. So first, I'm requesting Professor Mohammad Saifullah. Sir, would you please give some valuable note on the first presentation that was by Dr. Sarah. The corneal edema after cataract surgery, what are the causes?
Thank you. Thank you, Dr. Shara, for her nice and elaborate presentation. Actually, I have a little bit, he left a little bit for me to say. There are a lot of causes for corneal edema after cataract surgery. So there is pre-existing endothelial disease like Fuchs, endothelial dystrophy, pseudoexfoliation, trauma, angle closure glaucoma, etc. And then intraoperative factors are irrigating solution, excessive instrumentation and prolonged surgery, and also the sterilization technique, ultrasound heat produced by the phaco machine causes damage to the endothelium, vitreous loss, drug toxicity, intracameral anesthesia, Descemet's membrane detachment, all are the causes of intraoperative factors. So I'm not, there are some other postoperative factors like long-term cell loss, vitreous touch to the endothelium, IOL dislocation that may causes damage to the endothelium, and also the flat anterior chamber, peripheral anterior synechia, pseudophacodonesis, inflammation, toxic materials. All of these things are described by Shara. Thank you, Dr. Shara. I'm not going to repeat all these things. Thanks to Shara for our presentation, and thanks our respected audience for their nice participation. Thank you all.
Thank you, sir. Now I'm requesting Professor Chandrasekhar Majumdar sir to talk on something about the appropriate preoperative evaluation for cataract surgery, which was presented by Dr. Mohammad Ashraful Haq.
Good evening, everybody. Honorable panelists, respected speakers, moderator, and distinguished audience. Thank you all for arranging and attending such a valuable and interesting topic and demanding scientific program. Cataract surgery leading to corneal edema is a challenge for the cataract surgeon. So appropriate preoperative evaluation is necessary for cataract surgery to prevent postoperative corneal edema. Corneal edema impairs visual acuity and sometimes leading to bullous keratopathy and corneal decompensation. Bullous keratopathy is a very painful condition. Dr. Ashraful Haq described appropriate preoperative evaluation for cataract surgery very nicely and elaborately. Thank you, Dr. Ashraful Haq, for his excellent and outstanding presentation. Here, I want to tell or add something. Specular microscopy is important, as well as tachymetry is also important. Dr. Rajashree Das already mentioned, if corneal thickness is more than, central corneal thickness is more than 640 micron, corneal edema may develop. So tachymetry is very important. It should do as preoperative evaluation for cataract surgery. Another is anterior chamber. Anterior chamber is if anterior chamber is shallow. Anterior chamber, there may be corneal endothelial mass and endothelial injury, and postoperative corneal edema may occur. Another is poorly dilated pupil. Dr. Ashrafullah already mentioned history. We should take history of drug history, especially drug history. If patient is taking tamsulosin for BP, in this case, people will be very difficult to dilate, and surgery it will render surgery very difficult, and corneal edema may occur. Anterior chamber depth should be adequate. It should be so preoperatively anterior chamber depth should also be measured. Another is important thing is cornea morphology of the cataract. Dr. Ashrafullah already mentioned morphology. We should, in case of black cataract, if we do phacoemulsification, more phacopower will be needed, and corneal injury will occur, and corneal edema may occur. So it is better to do small extracapsular small incision cataract surgery rather than phacoemulsification to prevent corneal edema. Another thing, contact lens. We should take history of using contact lens. If patient wear contact lens, this contact lens should not be worn up to 1 week before cataract surgery to allow adequate corneal stability. And if patient worn RGP, it should not be worn for up to 2 weeks. Otherwise, everything is already all thing is mentioned by Dr. Ashraful. I am again giving thanks to all for patient sharing. Thank you all.
Thank you, sir. Now I am requesting Dr. Torikul Alam to give his input on phaco-dynamics related to corneal edema, man versus machine, presented by Dr. Muntakim Shahid. Sir, you have to unmute first.
Yeah. Is it okay now?
Yeah.
Okay, thank you. Thank you very much. First of all, thank you all for considering me as a panelist in this wonderful session. And with phaco-dynamics, all the presenters have presented their cases so well. I think I have learned a lot from this session. And all the one, I'm not going to mention the names, starting from Sarah, then Ashraf, then Muntakim Shahid, then Tariq, everybody have presented so well. I think it's so valuable. But with Shahid, phaco-dynamics, I think there is nothing fixed in this regard, but which should be the perfect dynamics. For surgeon to surgeon, it's the man versus machine, which dynamics will always depend upon the man behind the machine, who is using the machine. And every surgeon's dynamics, I think, will differ from the other in accordance with his skill, experience, and others. Well, there might be some, what should I say, default dynamics or preset dynamics or preset on soft cataract or medium hard cataract or very hard cataract. There should be there will be a lot of talkings regarding the continuous pulse mode, linear mode, fast mode. It all will go with the surgeon, with which he is accustomed to and expert in. That's all. I think they have presented that case very. Thank you very much. Thank you.
Thank you, sir. Thank you for your nice input. Now I am requesting Professor Sarwar Alam sir to give his input on advancement in the management of the post-operative corneal edema by Dr. Rashid Alam.
Thank you, everybody. Actually, all the presentation are so nice and sufficient. Little to comment about Russell's presentation. I'm not going into the surgical details, but in general, the latest modalities, surgical modalities for treating this thing. We must know a little bit of the development process. In 1998, Meles developed DLEK, where the donor was cut to the seizures, and it was a very good method. It didn't popularize. Then he revised the technique and manual dissection of the dissected posterior laminar donor button. Then he put it into the Descemet's membrane and endothelium stripping. This is modified dissect. Later on, Mark used microkeratom for using that thing for having a smooth surface and good quality tissue. And it was known as a dissect.
1000.
Then Meles further developed it and used only the donor, took the donor Descemet's membrane and endothelium, that is called DMEC. And in USA, we don't have much statistics and much corneal tissue. In 2014, the DSEC procedure was about 90%. And after 3 to 4 years, it came down to 70. And DMEC procedure was 90. From 90, it has risen to 30%. So the popularity of DMEC is rising because of its excellent outcome. But we must think of problem in DMEC. It is technically more difficult. Getting the tissue and handling the tissue, learning curve is more. If we want to say the case selection, we must have to go through the endothelium risk factor matrix before cataract surgery, which has been described to some extent, but there are others, the low risk, moderate risk, high risk, very high risk before cataract surgery. Then we will find less surprises in the post-operatively. Another thing is that many times after endothelial decomposition, people are sending cases to the tertiary center, please do PK or something. But at least some waiting time should be there for if the peripheral cells are, endothelial cells are good condition, so they can take over and have some 3 months, 3 to 6 months should be observed before taking any decision for surgery. And also, before that, we should continue the medical treatment. We many times are forgetting medical treatment, we opt for surgery. And about the options for surgery, if the antechamber is very shallow and dense scar is present, we will not opt for lamellar endothelial keratoplasty. We will opt for penetrating keratoplasty. If the antechamber is reasonable, but there is some haze in the anterostoma, we might consider DSEC. But for DMEC, a good anterior chamber, little haze is a criteria for doing DMEC. So they are more selective procedure. And about the a few points about the investigation facilities. Many center doesn't have all the investigative facilities, but we must know that in huge corneal edema, pentacam and ultrasound pachymetry don't give good results. Anti-segment OCT gives the best result in those cases, and optical pachymetry is better than ultrasound pachymeter. And last of all, what Rashid has said, that two other modalities, desmetorexis without endothelial keratoplasty is a new thing. It is limited to only the central gutata, where the periphery is clear. So desmetorexis is done, and in the hope that from the periphery there's some remodeling will occur and the edema will resolve. And the Rho kinase inhibitor is also used for those things. And endothelial cell injection into the antechamber by the Japanese, we are seeing in every seminar there is one paper, but still it is in the experimental stage. Whatever, at the end of the day, everything becomes theoretical if you don't get cornea. Without cornea, these are all theoretical possibilities. And getting cornea from outside and risking that cornea for malhandling and getting worse and getting money from the patient is a very risky procedure. We cannot progress with this thing. So our primary aim should be to get local cornea, and learning curve is more than any other surgery. So more training should be done, but Bangladesh is going ahead with the young surgeons. We are hoping. Thank you.
Respected audience, welcome you to the so attractive quiz for residents in 40th Annual National Conference of OSB. Today's session is chaired by Professor Mohammad Shakuddin Ahmed and co-chaired by
স্যার এটা কোথা থেকে
co-chaired by Professor Mohammad
এটা পাশের থেকে চলতেছে, পাশে আরেকটা ওষুধ চলতেছে।
OSB and Professor
হ্যাঁ স্যার
I finished my talk.
Oh, thank you, sir. Thank you for a nice introduction. I think the presenter here today all are your mentee actually. So it's a nice mentor-mentee interaction. Now I am requesting Professor Abdul Qadir sir to talk on something on the Fuchs endothelial dystrophy with cataract, the post-operative surprise, and at the same time the wrap up this session.
Thank you very much, Dr. S.M. Enamul Haq, for your nice moderation and timely.
Sir, unmute করতে হবে স্যার।
Thank you, Dr. S.M. Enamul Haq, for your nice moderation and timely to be ending this session. All the speakers tell their topics very nicely and elaborately, and all the videos are very much attractive. Now, I like to concentrate to Dr. Rajyasree Das' presentation. She's done his job very well, and I congratulate her. I like to speak regarding Fuchs endothelial dystrophy. The important thing is Fuchs endothelial, the symptom is more in the morning and gradually decrease the symptom in the evening. When this type of symptom with the patient come to us, we do specular microscopy, pachymetry, as well as intraocular pressure. These three things is very much important, as because Fuchs endothelial dystrophy is associated with female patient, middle-aged patient. They usually have the rise of intraocular pressure with cataract. So this thing very much important. Another important thing is how we do the phacosurgery. What will be the next? What will be the next procedure? Next procedure is ultimately, if there is post-operative edema of the cornea, we go for the endothelial keratoplasty. we have no endothelial cartilage. So what we can do? We do, if there is cataract, view is very good, we do the phagosurgery with intraocular lens implantation. If view is not good, then we go for endothelial keratoplasty. So this is the message. Thank you everybody, every panelist for nice their comment and all the speakers for their nice deliberation. I am very much delighted to ending this session. Allah Hafiz.
Thank you, sir.
Thank you very much. সবাইকে খুবই ধন্যবাদ জানাচ্ছি যে এইটা সবচেয়ে হাইয়েস্ট পার্টিসিপেন্ট কিন্তু এখানে ছিল।
থ্যাংক ইউ স্যার। সব পার্টিসিপেন্টকে ইয়ে করছি। আমরা পাশে আরেকটা সেশনে কুইজ প্রোগ্রাম চলছে, তো সো ইউ ক্যান জয়েন দ্য কুইজ প্রোগ্রাম simultaneously. I am ending this session now. So thank you. Thank you, sir.
Excellent.
Assalamu alaikum.
Recording stopped.